Welcome to episode number 23 of Reimbursement Readiness, Business Tips for Wound Practice, presented by Kathleen and friends. I am so glad that you have taken time out of your busy schedule to join Donna Cartwright and me today. In many of our earlier reimbursement readiness episodes, we have explained the importance of documenting the who, what, where, when, and why that explains the patient's condition and the medical necessity for the work performed at each encounter. Unfortunately, an increasing number of wound and ulcer management professionals and providers are undergoing audits and are receiving additional documentation requests for a sizable number of specific patient encounters. Now, often when this occurs, those professionals and providers call me and ask if they can amend their medical records before they submit them to the auditors. No matter how many times I receive the same question, I am always surprised that they ask it. Therefore, I invited Donna Cartwright, who performs many friendly audits for wound and ulcer management professionals and hospital-owned outpatient provider-based departments, to once again address documenting correctly. I also asked Donna to discuss late entries, amending, and correcting medical records from her perspective as a friendly auditor. Welcome, Donna. The listeners and I are anxious to learn from you today. Take it away.
Thank you, Kathleen. Basically, we're going to talk a little bit about the Medicare Program Integrity Manual first, because I want you to know where these rules are so that you can find them if you find it necessary. So 3.3.2 in the Medicare Program Integrity Manual says the medical review guidance, and it was revised in October of 2020. It became effective August 27th of 2020, and it was implemented on August 27th of 2020. So these informations that I'm providing you with are absolutely not new. And this section applies to any MAC, to any CERT recovery audit contractors and UPICs as indicated, and describes the requirements that the MACs, the CERTs, the recovery auditors, and the UPICs have to follow when they are reviewing submitted documentation. So the UPIC staff looks for some of the following situations when reviewing documentation, and these are important to keep in mind when you're taking a look at your records prior to sending them in. They are also looking for the following: possible falsification of evidence of alternatives, including but not limited to obliterated sections, missing pages, inserted pages, whiteout, and excessive late entries. Most of you are aware that Joint Commission does not allow whiteout in your entries in the medical record. They're also looking at evidence for evidence that the service billed for was actually provided, and that patterns and trends that could indicate potential fraud. So that's what they're initially looking at on a regular basis. So they have a special section for Medicare on amendments, corrections, and delayed entries in medical documentation. And these were updated and effective June 10th of 2024. So these are a little bit more recent. And this section applies to MACs, CERTs, RACs, SMRC, and UPICs as indicated. All services provided to beneficiaries are expected to be documented in the medical record at the time they are rendered. That's a very important clause, at the time they are rendered. Occasionally, certain entries related to services provided may not be properly documented. In this scenario, the documentation may need to be amended corrected, or entered after rendering the service. So the date and author of any amendment, correction, or delayed entry has to be identifiable, and the change addenda should be clearly and permanently denoted in the medical record. Contractors shall deny review of any amendment, correction, or delayed entry in accordance with section 3.3.2.4 of this chapter. And if any of those agencies identify documentation with potentially fraudulent entries, the reviewer shall refer those types of cases to the UPIC and may consider referring to the RO and the state agency. So a lot of people ask me, Donna, do we have an opportunity to send a rebuttal against the findings of one of these types of audits? And basically the answers are in the same manual. General providers or suppliers have the right to submit a financial rebuttal statement in accordance with 42 CFR 405370-375, following the receipt of the review results letter and prior to the recoupment of the overpayment. The rebuttal statement and any accompanying evidence must be submitted within 15 calendar days from the date of the results letter, unless the MAC staff finds cause to extend, shorten that time frame for any reason. So review of the rebuttal statement within 15 calendar days of the receipt of financial rebuttal, the MAC staff has to consider the statement and any evidence that's been submitted to reach a determination regarding whether the facts justify the recoupment. However, the MAC shall not delay recovery of any overpayment beyond the date indicated in the review results letter in order to review and respond to the rebuttal statement, even if the principal of the debt is modified after reviewing the rebuttal statement. So again, I gave you a citation from 42 CFR. And the MAC shall provide a copy of the rebuttal request and a copy of the MAC's response on the rebuttal outcome to the UPIC. So let's take a look at what one of our MAC contractors says about amending medical records. And this is taken from Noridian. Late entries, addendums, or corrections to a medical record are legitimate occurrences in documentation of clinical services. A late entry, an addendum, or a correction to the medical record bears the current date of that entry and is signed by the person making the addition or the change. Definitions of late entry. Everybody has asked me, Donna, what is a late entry? A late entry supplies additional information that was omitted from the original entry. And a late entry bears the current date, is added as soon as possible, is written only if the person documenting has total recall of the omitted information and signs the late entry. So I give you an example. A late entry following the treatment of a multiple trauma might add the left foot was noted to be abraded laterally. John Doe, MD 61509. So that's an example of a late entry. A definition of an addendum is used to provide information that was not available at the time of the original entry. The addendum should also be timely and bear the current date and the reason for that addition or clarification of information being added to the medical record and be signed by the person making that addendum. So for example, you could say the chest x-ray report was reviewed and showed an enlarged cardiac silhouette. Signed John Doe, MD 61509. So what is the process to actually make the correction? When you're making the correction to the medical record, you never write over or otherwise obliterate the passage when an entry to a medical record is made in error. You simply draw a single line through the erroneous information, keeping the original entry legible. Sign or initial and date the deletion, stating the reason for the correction above or in the margin. Document the correct information on the next line or space with the current date, time, and make reference back to the original entry. So correction of electronic records should follow the same principles of tracking both the original entry and the correction with the current date, time, reason for the change, and initials of the person making the correction. And you can refer to your EHR guidelines in your own facilities. And of course, you can always consult with somebody from your health information department, as they will be able to help guide you with that. When a hard copy is generated from an electronic record, both records must share the correction, and any corrected record submitted must make clear the specific change that was made, the date of the change, and the identity of the person making that entry. So I gave you a few resources where I got that from, and you can use those at your own leisure. So I figured I would give one more example of MAC guidelines about entries into the medical records. And this statement is from Palmetto, and it was published on January 25th, 2022. Entering information into the patient's medical record in a timely manner is important for many reasons. CMS provides some guidance regarding what is considered timely for Medicare purposes. And this is really important. We strongly encourage all healthcare providers to enter information into the patient medical record at the time the service is provided to the patient. That is contemporaneously. So, meaning you need to do it as soon as you can following the procedure, okay? CMS recently published established record-keeping principles to provide further guidance regarding the timeliness of entries in the medical record. And these principles apply to all of the Medicare contractors that review medical records, including the MACs, the CERTs, the RACs, and the Unified Program Integrity Contractors, the UPICs, in all cases. So let's look at a few do's and don'ts based on what I just communicated. So do clearly and permanently identify any amendment, correction, or delayed entry as such. Clearly indicate the date and the author of any amendment, correction, or delayed entry. Don't delete, but instead clearly identify all original content. For paper medical records, making the corrections you need to keep within these principles. Generally, it means using a single line strike through the original entry with an initial and a date. The author of the alteration must sign and date the revision, and amendments or delayed entries must also be signed and dated by the author upon entry. For electronic medical records, electronic signature providers using electronic signatures, there is a potential for misuse or abuse with some of these methods. For example, providers need a system and software that protects against modification, et cetera, and should be included in the administrative procedures that correspond to the medical staff bylaws. So a little bit of guidance, and this is from Donna. After 30 to 90 days, use only with a clear justification about the results, and clearly label and date those late modifications. Those modifications without an explanation for that modification can trigger audits. After 90 days, if you are updating things after 90 days after the date of the service, it is a very high risk to you under audit, because modifications are presumed fraudulent unless it's proven otherwise. And this timing can lead to claims denials, Medicare recoupments, fraud referrals, and lost revenue from audits. So those are the danger zones that you need to be careful of. Considering that the real danger zone is corrections that are made after 90 days, I wanted to point out that one of the most common questions that both Kathleen and myself have received when a provider is getting audited is, should I go back and change my records that are being requested for the audit? And the answer to that is a little complicated, but it'll make sense in the end. Because if 90 days is a danger zone, definitely charts that are a year old are definitely danger zones for going back and making those changes. Now, that's notwithstanding that if the auditor allows you to make the change, if you've explained yourself during the meeting or whatever, and they allow you to go back in and make that change, that's different. And you would follow the same procedure, sign and date it. And basically, you would say the Medicare auditor um, allowed you to make that change retrospectively. So that's very important that you realize that. And again, when you get a request for audit, say you get a request for audit for 25 charts, and you send a cover letter telling them everything bad that you've done for the past year, you're helping the auditors. So I would probably have you wait until after you receive it back from the auditors, especially for older charts. Concurrent charts different, but for older records that are being requested under audit, you're better off trying to appeal it and question it to make that change. And that can be part of your rebuttal. So I hope you find that helpful. And again, not necessarily a great idea. And audit trails must track identity of the user who made the changes, and most electronic systems will do that. Log the date and time of the changes, preserve the original entry, and without these audit trails, even a legitimate correction could appear to be fraudulent. Complete your documentation within 24 to 72 hours of the data service, and use clearly labeled addenda or late entries, and never delete or obscure any of the original entries. So these are the best practices that I have found in my travels. Now, of course, you're also going to have to comply with your medical staff bylaws and Joint Commission requirements for documentation in all cases. So it's not just the MACs, but your internal facility. Again, your medical staff bylaws has rules and timing for completion of, for example, discharge summaries, operative reports, and so forth. So you need to check with your facility guidelines as well. So I'm glad you were able to join us today. And as always, if you have questions on this topic or any other topics that you have heard recently, please email them to kathleenschaum@gmail.com. And Kathy and I will be happy to review those on a different episode when we receive them. And please provide an evaluation of this episode by clicking on the QR code that you can find on your screen. Thanks again for joining us today, and I hope you learned a little bit about the documentation rules. Thanks. Have a great day.
Thank you, Donna. I am so glad you explained these documentation correction rules to our listeners because there has been a lot of confusion. I'm very glad you emphasized the importance of not doing them past about 90 days and more importantly, to do them as soon as you can. Once again, I also want to thank our loyal listeners. Without you, reimbursement readiness would have no purpose. The entire reimbursement readiness team values your opinion of each episode. And as Donna mentioned, we would appreciate if you would please take a few minutes to evaluate today's episode. And you can easily do that by clicking on the QR code. And if you find these short reimbursement readiness episodes helpful to you and to your business, please share them with your colleagues in wound and ulcer management or revenue cycle management. Now, stay tuned for our next episode where we'll explore more strategies to improve wound and ulcer management operations and reimbursement. Until then, keep doing the right thing for your patients and for your business. I look forward to talking to you soon. Thank you so much.